This lecture is going to be on the basic EKG and on some basic cardiovascular disorders. Now, we're just going to understand the letters of the EKG. We're not going to go into any rhythms. You're going to get into rhythms next quarter and especially in critical care. But here I just want you to understand what is happening with those letters. We're also going to look at coronary artery disease, and you've learned about hypertension and you've learned about some other things going on with the heart. But now we're going to focus on a more chronic illness that you have that can go on in the body. Now let's remember what happens when you have your heart beats. We know about your pacemaker that God gave you. It beats 60 to 100 beats per minute, and that's your SA node that starts that impulse that goes down, and then it goes down to the AV node, which again is kind of in between the two atria and the ventricles on there, and that AV node then stimulates going down into the septum and then into your Purkinje fibers, and then that makes your ventricles contract, and then the AV node in of itself has its own rhythm and rate in case the backup of the SA node has problems. And that's the way God made you. He made you this beautiful compensatory mechanism. Let's review what happens in normal circulation. Remember, unoxygenated blood comes into the right atria, and then you're going to have two atrioventricular valves, and that tells you where those valves are. AV valves, atrioventricular, so between the atrium and the ventricles. On the right side you have a 3 valve, which is called a tricuspid valve, and that will let the blood go into the right ventricle. That right ventricle will then push the blood that's there when it pumps, the ventricles pump into the pulmonary artery. Now you have two semilunar valves for the left and the right, just like you have two AV valves for the left and the right. So on the right side it's the pulmonary artery because it's going to the lungs. Remember, this is unoxygenated blood, so it's going to send it to the lungs to get oxygenated, and that oxygenated blood then goes to the left atria, which will then go through a bicuspid valve, which is more commonly known as a mitral valve. That's the other AV valve, which goes into the left ventricle. And as we know from anatomy and physiology, the left ventricle is the bigger of the two muscles between the ventricles because that one has to go into the aorta, and the aorta is the one that sends that beautiful oxygenated blood to the rest of the body. So right atria, right ventricle, pulmonary artery, left atria, left ventricle, and out to the aorta to the body. Now, so when we look at electrical recording, remember you learned a long time ago in your anatomy and physiology class about action potentials. You learned about sodium and potassium. You learned about calcium going in and out, resulting in an impulse because there's going to be an electrical excitation that's going to send those muscles to pump. So the atria pump, then the ventricles pump, and that's where you get your lub-dub. So when we start looking at wording and when you start looking at your EKG, when they talk about depolarization, all they mean is that an impulse gets stimulated and it causes the muscles to contract. So depolarization just means the heart contracts. Repolarization means that the heart has to relax. It's not in a continual state of pump. It has to relax, and so that way it can pump again. And that repolarization, or returning to the resting state, is relaxation. So repolarization, relaxation, same letter, repolarization, relaxation, depolarization, contraction. So really all an EKG shows is those electrical impulses that cause those contractions of both the atria and the ventricles. So let's take a look at what that waveform is going to look like. It's a PQRST wave, and the reason they start with those is you'll learn it next quarter. I personally don't know. I'd have to look it up, but maybe we can discuss it when we're in face-to-face class. So these EKG tracings just represent the conduction of these electrical impulses. It starts with a P wave, and then the QRS is actually lumped together. It's referred to as one unit, so it's called the QRS complex. And then you have the T wave, and we'll talk about what each of those waves mean. So let's look at the P wave because that's the first one. Now when you look at EKG paper, you'll notice that there's a lot of boxes. There's little boxes, individual boxes, and then there's like a set of boxes, and that's where the boulder lines come in. All of those boxes mean is just a unit of time. Now when you get into the next level of med-surg, and especially when you get into critical care, you're going to have to be focusing on the time. Today we're just going to look at what do the waves mean and what are we looking at. So the P wave is atrial depolarization, and there's a certain amount of time that they want for that P wave to go. So don't worry about the time right now. Just understand that there's a set amount of time that we want that P wave to contract and have that atria contract or depolarize. Now, of course, when the atria depolarize, or when the atria contract, what do the AV valves do? Well, they have to open because when the atria contract, it's sending the blood into the ventricles. So when the P wave happens, that's when the AV valves are open. And so the time it takes for the blood to go into that ventricle is the PR interval. That's tracking that atrial impulse from the SA node to the AV node. So when that SA node to the AV node, remember, it's going to take a little time. It doesn't happen that instantaneously. It happens pretty quickly, but that is what we call our PR interval. That's why you see there's that little lag time between that first hump into the dipping of that ventricular contraction. We call that the PR interval. Again, please don't worry about the time. It's there because you will see it again next quarter, and especially when you get into critical care. So the P wave atrial depolarization. QRS complex is when we have the ventricles contract now. Now remember, the ventricles are a bigger muscle, so it's going to cause a bigger spike. That's why you see that big spike happening on there. So that's the contraction that ejects the blood from the ventricles and sends it into the semilunar valves, which is going to be the pulmonary artery and the aorta. Now notice it's a very quick pump, but that's because it's a bigger muscle. So of course it's going to pump much quicker and much more forcefully to get that blood where it needs to go. Now, remember, the atria doesn't stay in a continual contraction. It's going to relax. And what happens is, because the ventricles are a bigger muscle, it kind of buries where the atria relax. But where the atria relax is in that QRS complex. Because remember, the ventricles can't contract unless the atria relax. Because remember, those AV valves have to close. And the AV valves and the semilunar valves cannot be open at the same time. And so when the QRS complex happens, we're opening up and sending it through that through those semilunar valves, so the AV valves have to be closed. So you don't see the P wave relax because it's buried in the QRS complex. But that is when the atria will relax or repolarize, is when that QRS complex happens. So when that happens as well, remember, that's going to contract, and then those ventricles will have to relax. But in that little bit of time there, we have what's called the ST segment, and that's the end of when the ventricles contract, and then when the ventricles are going to start to recover. So what's going to happen is there's going to be a baseline. So when you hear that they have a baseline on it, that's all that means. Notice in the P to R interval, there's that flat line that's there. That is the baseline. And notice after the QRS complex happens, and while we're getting ready for those ventricles to recover and relax, notice it goes back down to that baseline. And so we look at that baseline, because when we start looking at some of your problems, you're going to hear something called an ST elevation. And notice in the other picture here, that ST elevation, that baseline is higher. That means that you have had some sort of heart issue happen, because it does not go back down to that baseline. Again, don't worry about the baseline. Just understand that there is a baseline, because you don't see the heart wandering all over the place. It really stays in a steady pattern. And that baseline will become important to you next quarter, and especially in critical care. So that's something to remember and to keep in your brain cells as you travel through your med-surg courses. Now, the ventricles are going to relax, and remember, because the ventricles are a bigger muscle, that T wave will look a little higher in that bump than the P wave does. And that's just when the ventricles relax. Now, because the ventricles are relaxing, you're going to actually see that relaxation or that repolarization happen, and that's what that next bump is, that little higher bump on there. So you have the P, the QRS complex, and then you have that T wave. And so remember, that's when everything relaxes and everything's getting ready to pump again. So right after that T wave, you will see the P wave in the regular heartbeat that you see. So again, when you have the Q, or the PQRS and T wave, notice on here that you will have that. Don't worry about the U wave. You will get the U wave when you start looking at your heart diseases again next quarter, and especially in critical care. The U wave is actually in relationship to the potassium. You know how we always talk about potassium and how it causes, if you have hypo or hyperkalemia, it causes that extra wave. That's what the U wave is, and you will learn that when you get into your higher levels of med-surg beyond us. Now remember, we have a PR interval. We also have a QT interval, and you'll hear about some medications that can prolong this QT interval. That just means we're going to affect the heart rate in some pattern, and so that's why they want you to be careful when they tell you that the QT interval elongates. It means that it's having a harder time for the heart to recover before the next contraction happens, and so that can be problematic for some of your patients who have heart issues. So those are the basic concepts that we're going to learn about today. So when you put it all together, here's our normal sinus rhythm, which is majority of you will run. So that little hump in there, that's your P wave. And then the QRS is when the ventricles contract, and then the ventricles relax, and that is your T wave. And then it just happens just all over again. Notice that they seem to come around the same level, and we call that your baseline. And that's just all of that. That's all that that means, okay? And that's all we want you to worry about this quarter. Now, you might be asked to put telemetry on a patient, and so this is how you place your telemetry on there. We have mnemonics. It's white is right, so white goes on the right side. Smoke over fire, so that's the black is on the left side. So when you look at the lower levels on there, if it's smoke over fire, the red goes below the black. The air over grass, and so white is air and green is the grass, so the brown goes in the middle. And you might hear it, there's several mnemonics. You can ask your nurses, there's several ways that you can put it on there. But white is right, smoke over fire, that's probably the most common that you will see. So white is right, black is left, green is below the white, and red is below the left, and then the brown is in the middle. Here's our telemetry monitors that we use across the way at the medical center, and these are typical ones on there, and you can see how the leads are color coded. The leads are usually very long, so that way that you can put it in the pocket and you don't have to worry about having short and the leads are clicking off. If you have to put telemetry on a person, please snap on the lead wires first and then take off the little sticky part and put it on the chest. Don't put the sticky stuff on and then try to put the pegs on there, because you have to push down, and that can cause some really uncomfortable pressure for the patient. So we always tell the patient, you know, snip, clip, clip, snap, snap, meaning click on the little electrodes first. Make sure that when you're putting it on the surfaces, especially if you have people who are really sweaty, please wipe the area dry first. They used to clean with alcohol swabs, so that way it allowed the skin to really dry. You won't see that as much anymore. They really just kind of wipe to make sure it's a dry skin area, and then they'll attach those electrodes on there. If you have somebody who has a fairly hairy chest on there, sometimes it's easier to shave it so that you really get good contact, because what happens is the hair sticks to the electrode and it causes the electrode to move because it's sticking to the hair instead of to the skin. So sometimes we do have to shave some of our patients in those areas. Don't shave the whole chest, just the area where you're going to put the electrode. There is a monitor tech who will tell you whether it's working or not, and they'll tell you what the rhythm is. So always check with your monitor tech, make sure that the telemetry is correctly placed on there. Now let's move on to our problems now that would require you to have telemetry, and that's coronary artery disease. Notice on here the most common cause of coronary artery disease is atherosclerosis. I know you learned about atherosclerosis last quarter when you were looking at your hypertension and some of your heart disease on there. And really the reason why we look at atherosclerosis is it's the most common cause for the narrowing of our lumens in our vessels. And when you narrow the lumen, remember, it's going to affect blood flow, so we're not going to get as good oxygenated blood where it needs to go, because part of it is blocked off because of the plaque buildup. And of course we know the plaque buildup usually is from anything from cholesterol to old cells that clump, lipids, any other kind of fatty substances that cause that fibrous tissue to stick together and decrease that lumen of your vessel. Notice on here in the picture, you can see the one on the very left. You can have that beautiful blood flow flowing, and then notice as you move towards the right, that plaque builds up. And you know, the plaque never lays like paint. It's never all over. It just, some places are more clumpy than others, and that's what will narrow the lumen. And then that's when we get into our issues like heart attack or our peripheral vascular disease that you'll learn about next quarter. So we already know that a lot of your atherosclerosis, so a lot of it actually comes from the diet, and depending on what kind of diet that you're on. And so again, we're going to look at our good cholesterol, our bad cholesterol, your actual amount of fat that you actually eat in the diet. So this is just a development of that atherosclerosis or arteriosclerosis. Those are used interchangeably and mean the same thing. So there are some things that we cannot change. If you have a family history of coronary artery disease, you are probably at risk. The older you get, you are at higher risk. You can see here men develop it earlier than women. After age 55, the gender actually doesn't matter. Everybody's at equal risk at that point in time. Usually after 55, men and women are both at risk. Men just get it at an earlier age. Again, unfortunately, just like in hypertension, your African Americans are at a higher incidence than the Caucasians are. And unfortunately, we're seeing a rise in the Hispanic and in some of your Asian populations as well. Again, there are some things, however, that we can change. We just talked about the diet and high-fat diet, and unfortunately, we live in high-fat, high-salt land here in the United States. Cigarette smoking, as we know, can cause vasoconstriction and also add toxins to the body, and so vaping, cigarette smoking, both of them can put you at a high risk for coronary artery disease. There are comorbidities that you need to control. One of them, of course, is hypertension. We've talked about hypertension last quarter. So if you don't have your blood pressure under control, or you're having a lot of vasoconstriction happening, and remember, if you've got that plaque laying in there, you are just adding to the narrowing of the lumen of your vessels. Again, same thing with diabetes. Diabetes, as you know, is a carbohydrate metabolism disorder. And so usually that means that you're having a lot of fat and sugar in the diet. And again, same problem. So if you don't keep your diabetes under control, same thing with the obesity. We can control weight. And remember, a lot of obesity sometimes is linked into the diet, although you'll find out that sometimes that is hereditary as well. And then, of course, the physical inactivity. If you're not moving that circulation around, if you're not utilizing the fat in the diet that you take, you will put the body at risk for the fat collecting, and then you're going to have your problems. Obviously, we want to do primary prevention first. So that's why we always push the diet. We live in a blue zone here in Loma Linda because we are known for people living to 100 because of our healthy diet, which is mainly a vegetarian diet. They say the Mediterranean diet because it uses good fat. It also uses very minimal cholesterol types of foods, and so that's the reason why it's recommended. They use a lot of vegetables and things like that. And then, of course, you want to do the physical activity. Not only is it good for you to keep the circulation going and uptaking all of the stuff that you're eating, but it also helps keep the body strong. We also recommend that you don't smoke. Please don't smoke, and no vaping either. And then if you are a diabetic, if you do have hypertension, take your medication. And please, make sure you understand why you're taking the medication. Control your sugars. Control your blood pressures on there. If you do have hyperlipidemia, which is, like I said, it's a family history of it, they have medications, which are your statins, so the Lipitor, the atorvastatins, or something else that you take. Understand why you're taking those. Fish oils, things like that, that help to manage your cholesterol levels. Make sure you understand why you're taking them, and then please take them as directed. We do look at our lipids on there because we do know that this is what contributes to the atherosclerosis in the body. Of course, LDL, is a low density lipoprotein. That's the bad cholesterol. Notice on there you want it less than 100. Please don't memorize these numbers. I would give you the numbers and then you have to determine, or I'll tell you it's high LDL or low LDL, and you need to understand what that means. Cholesterol is less than 200. Actually, they just lowered the level. It's actually less than 170 now. But again, that's neither here nor there. I would give you a reference range if that's the case. HDL is our good cholesterol, so you want that higher. So notice there 40, so you want that in the 60s for both men and women, because we do want that because that is our good cholesterol, our high density lipoprotein. Then of course our triglycerides, you want it less than 150 because of the fact that, and people who have dyslipidemia, those triglycerides run in like the 300-400s, and we don't want that. So just understand good cholesterol versus bad cholesterol. Don't worry about the numbers. Just understand you want low LDLs, low cholesterol, low triglycerides, and the only thing you want high is the HDL. That's the only number you want to see as a higher number. So that's what's important for your lipid profiles. Again, if I give you numbers, I would give you the reference ranges. Please don't memorize these numbers, but you should be aware of them because when you do your education, you will need this in your actual clinical setting. So what happens if somebody has chest pain? So first of all, what is angina? Angina really is the narrowing of the lumen, which is obstructing the blood flow to the myocardium. Basically, it's an imbalance of oxygen supply and demand. So you're demanding the use of oxygen, you don't have enough supply because of the fact you have narrowed your lumen because of the atherosclerosis. Now remember, when you have that plaque building up, and their plaque is sticky, so it can stick to more stuff as it goes through and actually cause a clot. And so what ends up happening is you have obstruction of blood flow. So what you have is you don't have complete obstruction, you have partial obstruction. And when you have partial obstruction and you don't get total nutrients in there, we call that ischemia. So when you have that pain from angina, that's your body trying to tell you, hey, I'm not getting enough blood flow through here. I'm having an imbalance of my supply of oxygen. And even though I'm demanding it, I'm not getting enough because my vessels are narrow lumen. And so usually what you have with somebody who has chest pain, they get short of breath, they're diaphoretic, they're cool, they're clammy, they feel like something heavy is on their chest. They may have pain that radiates from the left side down their arm, maybe to the back, maybe to their jaw. This is a very typical presentation of angina. Now there's two types. Obviously the one that we want to have is stable, because what it means is that it's going to be relieved by rest. And so anytime you have somebody who complains of chest pain, the first thing you need to have them do is just tell them, okay, let's just stop whatever we're doing here and let's see what happens if we just stop and let you rest. If it's stable, it's going to be relieved by the fact that they're resting, or what happens is the pressure lessens and they feel better. If it's unstable, what will happen is that it won't go away. It'll increase in frequency, and giving nitroglycerin, which is what NTG stands for, giving the nitroglycerin if they have it and they have it on their person. If it's stable, it'll be relieved with the nitroglycerin. If it's unstable, it will not be relieved by the nitroglycerin. If you have unstable, you should be calling 911 and getting ready to get your person to a hospital where they can be put on telemetry and we can do further evaluation. There is a third kind of angina pectoris, which is actually a coronary artery spasm, and it usually wakes the patient up in the middle of the night, and this is called Prinzmetal's angina. And while it is angina, it's not really a lumen problem. It's the coronary artery is spasming. In other words, it's like having well, you know what a spasm is, and that's usually what wakes a patient up. They do need to be followed up, but it doesn't require an emergent trip to the hospital, but it should be a little wake-up call, like I said, to do further follow-up with your primary caregiver. Now, anytime, like I said, you have somebody, maybe you're in the hospital and you're walking a patient, just have them stop, have them sit or rest in the bed or sit them down in a chair. Please make sure they're sitting up in semi-fowlers. If they're in their bed, put some oxygen on them. You could put anybody on oxygen, at least 2 liters, because remember, we have an imbalance of supply and demand of oxygen. So help them with giving them some oxygen to help meet that demand for that myocardium. Of course, you're going to take some vital signs. You're going to call the doctor. Please anticipate that they're going to get a stat EKG. We need to see what's going on with the heart on there, especially if they're going to be lending towards a heart attack because they're in unstable angina. So this is not something you have to do by yourself. Call for some help. Some nurses will come in and help you. The charge nurse will come in and help you. They'll help you get everything all set up, because all of this will happen probably all simultaneously, because if somebody comes in and help you, someone can put somebody on oxygen, somebody else can run and get the vital sign machine, somebody else can call the doctor. The important thing is get some help. Now, when you're doing your patient education, you need to tell the patient, hey, you know you have this thing going on with the body. You know we have this atherosclerosis in here. You need to understand, when you overwork and you overdo, this is what happens to the body. You could increase your demand and not have enough supply. So think about, okay, if you do this action, will it precipitate the anginal attack? How can I help reduce the anxiety so that way when the angina comes, I can also help relax? You should be doing the education of, here's what's happening in the disease, and here's what happens because of the fact that we're not getting enough oxygen supply in here. So a lot of education goes into this that you as a nurse can do. Don't let them get into the event where they're actually having the event, and then that's when you're trying to do education, because they're not going to be able to understand. They're going to be in too much misery and chest pain, and so are you. You're going to be really trying to get them to relax and making sure that they're not heading into a heart attack. So a heart attack basically is when you have a complete obstruction, and when you have a complete occlusion to the artery, just think about it. There's no more blood flow going to what's beyond the clot. So once you have an area that's clogged off, remember the area beyond where that's clogged off now is not going to get any oxygenated blood. It's going to quit working, and what's going to happen, the muscle is going to die. And once the muscle dies, there's really nothing that you can do. And when you have damage and death to the heart tissue on there, that's when we have what's called the heart attack, or the MI, the myocardial infarction. Now, every minute is just critical on here. So time is muscle. So if you feel like they're having a heart attack, Don't sit there and go, well, let me wait a few minutes and see if that's really what's happening. No, act on it, get that EKG, get him on oxygen, call the doctor, keep watching him, keep doing that, because it's really important, because if we can, we're going to try and open up that blockage on there so we can get that blood flow going, because we don't want them to lend into a heart attack where we actually lose tissue and we have tissue die off. So every minute is really critical. Notice on here, every 40 seconds somebody has a heart attack. This just tells you that there are people out there who they feel like, oh, I just have an ingestion, I'm just not going to do anything about this. And then they end up having a massive MI and they pass away. So every minute counts. Don't delay. Call 911. Stay with the person if this happens while you're out in the public. So if anybody who you think they're having a heart attack, it's better to call, get 911, get some help in there. So you can see their tightness, discomfort to the chest. They look like they're paying allegiance to the flag, because that's what we call a vine sign over their chest. Heart attacks happen. Now that you've gotten statistics about heart attacks, let's actually look at what is the physical presentation that you're going to see. The typical presentation is you're going to see somebody start to clutch their mid-chest, or maybe the left side of their chest, which is why we talked about pledge allegiance to the flag, because that's the normal presentation that you'll see. The other presentation you'll see that goes along with that clutching of the chest is probably a lot of anxiety. They're going to look a little gray. They're going to look a little clammy. They're going to say, oh my gosh, I think I'm having a heart attack. I think I'm going to die. So this feeling of impending doom. They might even be nauseated. Say they have a little indigestion, and next thing you know, they're having an MI. So when you take vital signs, it's not surprising to see they're tachycardic. Because of the anxiety, their respirations also speed up, so it's not uncommon to see the tachypnea as well. Of course, now that you see that your patient has chest pain, you're going to call the MD. The MD, of course, to cover themselves, they will order an EKG. The EKG, you can do it yourself. We have portable EKG machines on the unit. You can also page respiratory stat, and they will come and do the EKG for you as well. If they're on a telemetry monitor, call the telemetry person and tell them, hey, can you kindly record this because my patient's in the middle of having chest pain, to see if there's something going on. Of course, the EKG will give us also a really good picture, but if you can put your patient on a monitor as well, that will also help see what's going on at the present and ongoing. You can put anybody on O2 at 2 liters. I would put them on O2 because remember, you're having an imbalance of oxygen supply and demand going on right now because you're having a heart attack. So give them that supplemental oxygen so that we can at least get some oxygenated blood going around in the body, even though it's going through a small vessel, or not a small vessel, but a lumen that has been interrupted and has been impeding the blood flow. At least the blood flow that's going in there is well oxygenated. If they're unstable, call a rapid response. Get some help up there to help you. Remember, if they find out the patient's really unstable and the blockage has gotten worse to the point where it's going to really occlude the vessel and cause a true MI where the tissue actually dies, then we're going to get them down into the cardiac cath lab so we can open that vessel and get that perfusion and perfuse that part of the heart so it isn't going to die. What drugs are you going to anticipate giving? Our mnemonic for chest pain and heart attack is MONA, morphine, oxygen. You already have them on oxygen. Morphine is a narcotic, as you know. We mix it with saline and titrate it slowly into the patient. And what it'll do is it not only will it help alleviate the anxiety, it actually also helps alleviate the pain. And of course, when the person relaxes, it also causes a bit of increased circulation because the person isn't vasoconstricting anymore because they're more relaxed. So again, that's going to help promote that oxygenated blood going into the much needed areas that need the oxygenated blood. Nitroglycerin is the N. Nitroglycerin you could give sublingually, and the nice thing about nitroglycerin is you can give it every 5 minutes sublingually. And usually after 3, if the pain is really not alleviated, we really suspect that they're having a true heart attack at that point in time. But it will help because it causes that vasodilation. And again, remember, we're trying to open vessels up so we can get oxygenated blood, because an infarction is tissue death, and we don't want the infarction to happen. We really are trying to get that oxygenated blood to that area that really needs it. Aspirin inhibits platelet aggregation, so you want your aspirin on there because that allows for a smooth flow. So the stuff that sticks isn't going to stick and cause
more occlusion that can happen in the vessel. Something that we found that's really been helpful with heart attacks is the use of a beta blocker. And the beta blocker, as you've known from last quarter, helps promote and decrease the cardiac demand because it promotes efficient heart pumping. And so that's why we'll utilize it, because it will slow the heart rate down. It helps to promote the pumping of the heart, so that way that will help decrease the blood pressure because you're getting a more efficient blood flow out to the body. So that's what's helpful in the use of the beta blocker. So for our medical management, you'll see on here the three big drugs that we really try to use besides the morphine, which will help alleviate the discomfort. It really doesn't do anything for circulation. It's really about discomfort. Are the nitroglycerin, which causes vasodilation, the metoprolol or the beta blocker, see that LOL over there, because it helps reduce that myocardial oxygen consumption because it makes the heart beat more efficiently, and the use of the antiplatelets, whether you do a true antiplatelet like a Plavix or a Ticlid maybe, ticlodipine, that's another drug that's an antiplatelet, or you use the aspirin, and this is usually a chewable aspirin, about 180 milligrams that they give on there, because that also causes and prevents the platelets from sticking and causing more stickiness to that clot. The laboratory test that we utilize is the cardiac enzyme panel. The cardiac enzyme panel is only actually consists of 3 tests. Myoglobin is actually not one of them. The cardiac enzymes that we look at are troponin, CK alone, and CKMB. CK, of course, stands for creatinine kinase. And creatinine kinase and CKMB are different types of isoenzymes, and they are found in heart, brain, and skeletal muscle. And so it's a very cardio-specific isoenzyme. So obviously, if you have some sort of muscle damage to the heart, that enzyme level will be elevated. But the gold standard, the true standard that we utilize, is troponin. Troponin is a protein that's only found in the myocardial cells. And that's why it's the gold standard, because the heart cells are the only ones that will be elevated if there's true injury. That's why troponin remains the gold standard. Now, troponin actually in and of itself actually has a more sensitive troponin level you could draw called troponin HS. And you'll see that in the little pictorial representation here on this slide. So troponin HS just stands for troponin high sensitivity. So this is actually more sensitive, and so this will actually tell us a truer picture of really what's happening with the heart. And please don't memorize any numbers. If I give you numbers, I will give you a reference range of numbers, and then I'll give you a value, and you should be able to tell whether it's higher in the reference range. Remember, if you have true cardiac events happening, all of these numbers are going to be elevated, both troponin, CK, CKMB. Myoglobin is found in skeletal and heart muscle. It's not a very predictive test of the heart attack. Obviously, it will go up because it is found in the heart muscle, but it takes a long time for it to go up. So, that's too long for us to wait. So we really go by the troponin, the CK, the CKMB. That is your true cardiac enzyme panel. Now we're going to open up that clogged artery. So in order for us to do that, we have to thread a catheter up in there. Before we do that, we're going to shoot a dye in there. So if you shoot a dye, remember, if you shoot a dye into any vessel, you need to check for your allergies. Always check for allergies to iodine, betadine, shellfish. We make them NPO before the procedure because we want the dye to really show up. And so if you are slightly dehydrated, that dye actually shows up better. And that's really what we want. We want to really see where is this occluded vessel. So we will make them NPO. Of course, we're doing baseline vitals, and we're doing a baseline EKG or ECG, that tracing of the heart. And then remember, we're going in the femoral artery, which means we're going to be occluding the vasculature down into the leg. So before they do the procedure, they're going to make sure this person has pedal pulses. And in fact, not only do they find the pedal pulses, they actually will mark where the pedal pulses are. So as soon as the procedure is done, we just go right to that area, and you should have the resumption of those pedal pulses or not see any change, actually not resumption, so much as that there's no change in those pedal pulses. If there's any change in the pedal pulses, or if they are different and they're less than what they were before, please let the doctor know right away, because we need to make sure that we haven't now caused 2 problems: occlusion in the upper part and now occlusion in the lower part because of the leg. So that's why the baseline pedal pulses are very important. They will be checked frequently after the procedure is done. They're usually checked hourly for about 4 to 6 hours. Now, what is is exactly that we're doing. Well, we're doing what is now called an angiogram, but it's actually called a percutaneous coronary intervention, so PCI. So as you can see there, we thread the catheter into a femoral line, threads up into where that occluded vessel is. We slide that catheter into there. That catheter has a balloon. They puff up the balloon. Notice that the balloon puffs up and it squishes stuff to the side. And then after a little bit, they'll close that balloon off and you see it leaves that stent, that wiring that's on there, that's going to keep that occluded area from re-stenosing or reclosing off, because now it's giving us a little structural integrity. Now, if the patient does not do any lifestyle changes in order for this to work, what's going to end up happening is that it's going to reclose. So that's why the lifestyle must be and education must be included in doing this intervention, because you do not want them to have this happen again. Also, PCIs are only used for one vessel. It is not used for multiple vessels. We'll talk about CABG a little later on in this lecture. That is the one that we use for multiple vessels. But PCI is only used for one significantly or severely occluded vessel, and we're trying to prevent a myocardial infarction or death of the tissue. How does PCI work? Let's look at the next slide.
Cardiac lab, and she gave me this video. Just watch very quickly. Look at that. So this is an actual cardiac cath on there. You can see how it reperfuses, and it opens very, very quickly. So that's the beauty of having that. It just opens it right up, and notice how that circulation now reperfuses the heart that didn't have that circulation before. Now remember, after this is done, we are in the femoral artery. It's an artery. It can bleed. So you can see there, if it bleeds, it's going to cause horrible bruising. That is called a hematoma. So when you have that hematoma on there, you have to be careful, because remember, hematoma just means it's a bruise. It's bleeding underneath the skin. So you want to make sure that they apply pressure. This patient has to be on bed rest at least 6 hours post-operatively. Or post-procedure. It's not an operation. It goes actually into interventional radiology. So if they do have bleeding still, then you need to apply pressure on there and apply a pressure dressing over the catheter access site. Now you need to also monitor for bleeding when they get back, because most people aren't bleeding, but if they walk too soon, they will start bleeding again. So you need to make sure that you are holding pressure on that site. The other thing you need to check for is those pulses. Remember, we looked at those pulses before we went into the artery. Now we've closed it off. But if you've got bleeding like this and you've got a hematoma, we could actually cut off the circulation to that, and then you will not get any circulation down into your leg. So therefore, then you're not going to have any pulses in your leg. And when that happens, you need to call the doctor right away, because you do not want to have an occlusion in that femoral artery, because then you're going to cut off circulation to the leg. You could end up having an amputation because you have no circulation. The other thing you have to watch out for is that when we're threading all this stuff up, we could actually loosen a clot and actually send a clot and cause an embolus. So if a patient has chest pain or bleeding, or actually has sudden discomfort from in the chest, they might actually have had a clot thrown. And again, that's going to be that's an emergent situation for pulmonary embolus. And again, you're going to need to call and get some help for that. Now, the problem with doing this PCI is if the patient does not do any health changes on there, he can re-stenose. The other problem is that, yeah, you stretch all the stuff to the side, but that doesn't mean that, you know, you don't change your diet, more plaque comes, it's still sticky, it's still going to stick on there. And we don't really do PCI for multiple vessels, so we're not going to say, okay, let's go in this artery, then in this artery, then in this artery. We really just go to the one that is the most occluded, and then they'll decide what do we need to do with the other vessels on there. So if the client doesn't make any lifestyle changes, this is not going to be helpful. This is where the client needs to be their warning sign and say, hey, I need to change what I'm doing. And that's where the education for you as a nurse is very important for the client, so that they understand if they don't make any lifestyle changes, this could happen again, or something worse. If that something worse is now we have multiple vessels clot off, then we have to do what's called a coronary artery bypass graft. You know it as a CABG, and this is not the vegetable. This is a CABG, and this is where we actually bypass the occlusion, because the occlusion is so great, or it's in multiple sites, that we can't go in, like I said, with the PCI and just go blow up all of those empty or those blockages. So what we have to do is we have to do a workaround, or what we call a pass around on here with the bypass. What they do is they use a vein that's in your leg, and they'll take it up to the heart, and they use that to bypass the blockage, so that way your heart gets reperfused. So the thing with the bypass graft is that if you have multiple sites, this is where you hear, oh, I had a triple bypass, oh, I had a quadruple bypass. So there were 3 areas or 4 areas in the heart that were so clogged off that we could not open it, and so we had to do this bypass on here. When they do the actual bypass on there, they actually do put you on a heart-lung machine and actually turn off the heart while they do the bypasses really quick, and then they will turn and get your heart rebeating again to make sure, because otherwise, if you think about it, while your heart's beating, if you're trying to do this, the blood's going to be pumping out all over the place, you know, around your sites that we've done the bypass on. That's the reason why they actually turn you off while they sew everything all together on your bypasses. Then they turn the heart back on. So a CABG is a very it's a very dangerous procedure, but sometimes it's really, really necessary on there. And some of you might be working on the heart floor when you are done here with your nursing career, and you will see these patients on your unit. These patients go to ICU afterwards on there. You need to make sure that the heart is beating. They'll be on telemetry. They'll be followed up with all of the cardiac markers. Obviously, these people are going to be very fragile, so repositioning, while it's important, you also need to make sure that you do it very safely. Some of these patients, they actually leave the heart open with a sheath on top of it or a covering on top of it while all the swelling goes down from all the work that they've done on there. Some of you will see that on your cardiac units. But the important thing is that the heart is getting perfused, and so that's why it's so important that we look at the oxygenation, making sure that the body still gets hydrated, and making sure that our cardiac markers are still doing okay. Now remember, complications of immobility, pneumonia, skin breakdown, constipation. You know, constipation is like the last thing you're worrying about when you're worrying about the heart, but you do need to keep those things in mind when you're taking care of your CABG patient. You can see here all sorts of complications. We talked about bleeding because it could leak at the site. So you can see here, there's your bypass sites that you can see there, those extra ropes that you see there going on the heart. They could actually, because of the fact, you know, they had to stop the heart, you could actually have had an MI, you could have had fluid overload, you could have blood pressure issues, you could have, you know, oxygenated blood not being enough on there, you know, and if you don't get good perfusion, you can kill your kidneys. There's just so many complications. That's why these people go to ICU, because they really need to be watched very carefully. And notice on here, obviously sepsis, infection. You've got this open heart on here. You need to make sure that everything remains clean so that these people do not get an infection. Anyway, that's the end of this particular lecture. We will talk about more of this in face-to-face and class. So thank you for listening. Please bring your questions to class, and I will see you then. Thank you.